Okay, so we'll go on now and talk about the medial ligaments, the deep ligaments of Tibio-talar and the superficial of the Tibionavicular, Tibiocalcaneal, and kind of the spring ligaments on the medial side. So let's start with the deep one is really familiar with, is the deep deltoid ligament here. Hi, Michael. We're just starting. And familiar, it goes from the medial malleolus to the medial aspect of the talus, as a typically striated appearance. If you don't see the striations, that typically means that there's some tendinosis or some degenerative changes going on, or an old injury, but probably does not lead to any significant changes in management. That's the primary one we look for. There are also the deep ligaments. There's an anterior. If you go anteriorly, there's a little ligament here. There are a few other things which we normally don't look for because it's just small. If we look at the superficial ligaments, there's the tibionavicular. I'll show one example of a torn tibionavicular. This is one that we typically don't evaluate. It tends to be thin and a little bit difficult to see by imaging criteria. The tibiocalcaneal, which is important in the tibio-talar back here, and then the calcaneal navicular ligament down here. So superficially, posteriorly, we can see here's the deep deltoid here, and here we can see the more superficial ligament. This is the tibiocalcaneal ligament coming down through here, and then this is the posterior tibialis tendon here. And the deep tendons here, the tibiocalcaneal ligament, and the oblique portion of the spring ligament, superior portion that we'll talk about later as well. And if we go more anteriorly, here we can see the anterior ligament coming down here, the tibionavicular ligament coming down through there. Okay, in the axial plane, the spring ligament is really a deep structure here. Here's the navicular, the talus. The tibiocalcaneal is superficial to the spring ligament, deep to the tibialis posterior here, and then the flexor digitorum longus is right back in this area. The flexor hallucis longus is back here. And if we go up a little bit more here, we can see a little ossicle and distal PTT that we'll talk about later. So this is a 68-year-old male with medial knee pain. Ash, what do you think of this case?
Just looking at this 62-year-old medial knee pain, I think there is a tear along the talar articulation of the deep deltoid right there. Yeah, there's fluid. I don't know. It looks like a pretty extensive high-grade tear.
Yeah, this was a little tibial ligament avulsive injury in this location here, but it's not that separated in this particular case. And this would be typically from an eversion type injury, which distracts the medial side, and then you'd really want to look to see if you have an oblique fracture of the distal fibula on the lateral side with this kind of an injury. Michael, what do you think of this case?
Okay, this looks like probably a complete disruption of the deep and superficial fibers of the medial deltoid.
So John, here's the case where we can see the tear in this area, but I like the coronal images much better in this particular case. So this is a tibio-talar tear. So John, you looked into the definition of supination and inversion and eversion, and I'm sorry, I think the program crashed when you were talking about this earlier. Do you want to say any comments here?
Supination is where the foot basically medial side raises upward. That's the way that Dorland's describes it, and that's the only place I can really find it properly. And it doesn't address the ankle per se. It addresses the foot.
Okay.
And then it's basically like an inversion type of an injury.
Supination is where the lateral side goes
Pronation is where the foot goes inward.
Yeah, so the lateral side goes down in pronation.
That medial side goes down in pronation.
I don't think so. I guess we better go look.
This is where it's confusing.
Yeah.
The medial side goes down. You're getting, with pronation, you're getting a flat foot. With supination, you're getting a cavus foot.
Oh, okay.
And so when it comes to the hind foot, it's really not well defined.
Because at least the articles that I've looked at talk about pronation and inversion as being pretty similar motions, and supination and eversion being similar motions. So in this case, this is a supination injury where the talus would basically go into valgus. And with going into valgus, you get a stretching injury on the deltoid.
With supination, I would think that the talus would go into into the valgus position. That's correct.
Yeah. So that would cause stretching of the medial
The
ligament.
medial ligament would be stretched.
Right. So that's what we're seeing here. So this is a supination injury that's torn the deep deltoid.
But in a forefoot, it's entirely different.
Oh, okay.
That's what's confusing about it.
That is confusing then. Yeah.
And so that's when they use that terminology, it's like axial versus coronal imaging. That's why a lot of radiologists are confusing in that regard. So they should come out and just plain describe it properly, but they don't, and dictionaries don't show it.
So this was an article in Hospital Special Surgery Journal last year talking about deltoid tears, and these are due to supination external rotation injuries of the ankle, so-called SER injuries. And on plain films, if you look to see if the medial clear space is greater than 5 millimeters on x-rays, then it's, okay, not great.
Yeah, for the heel, that'd be correct. But for the forefoot, it's different. So that's where the confusion comes in.
Yeah, and here's, and then so this was just some data. If the medial clear space is less than 5 millimeters, then they claim the MR accuracy was about 80%.
One of the things about this area is you cannot allow the ankle talus and the tibia be separated. You have to have, you cannot allow any distance between the two. Yeah. In terms of the medial malleolus, for instance. So you have to have pretty much 100% in place, but there's some folks that allow for 1 or 2 millimeter separation, which I'm not sure that that's okay. It's a little confusing, and even in Campbell's.
In this article in Hospital Special Surgery Journal last year, they said that if the medial clear space was greater than 5 millimeters, that you should just go straight to surgery, and you don't need to get an MR, though most of the surgeons I know will get an MR.
Yeah, if you cannot reduce it. But that's the thing. If you can reduce it, you don't have to. That's the point.
Yeah, and then if they have injury in the medial clear space is less than 5 millimeters, they recommend getting an MR to evaluate the different structures and then decide.
Well, what I would do is I'd try to reduce the subluxation, and if I couldn't do that, then I would go for MRI.
Okay, all right. Okay, and then if we look at the medial ligament anatomy, here's the medial tibiocalcaneal ligament coming down through here on the coronal plane. There we can see it in the axial plane, and you have to follow it on several different images because it kind of is oblique, going from the tibia all the way down to its attachment on the calcaneus. Okay. Jennifer, what do you think of this case?
So there's diffuse disruption and fluid signal intensity in the expected region of the deltoid ligament, and it looks like there may be, I can't tell if that's just fat or if that's an ossific fragment. I think it's just fat. Okay. I don't see a cortex, so just diffuse disruption of the deltoid ligament. I don't see the attachment to the medial malleolus very well, which is unusual, but it looks like it's torn at the medial malleolus attachment and retracted. And there's an osteochondral lesion along the tibial plafond, and also looks like some osseous contusions on the lateral tibia and fibula, or sorry, talus and fibula.
So this was a Tibiocalcaneal tear. It also tore the deep deltoid and a SCR.
There seems to be a little rotation here, doesn't it, John?
Yeah, I think you always get some rotation in these injuries.
Unless they reduced it while they were filling with it.
Yeah, well, I think a lot of it probably reduced, but still, yeah, we can. So this is the typical appearance that you see in these eversion or supination eversion injuries of the ankle, as you might expect just from the mechanism of injury. Okay, Ashley, what do you think of this case?
Okay, so here, MLB player with persistent anterior medial knee pain. We can see that there is some.
This, let me just say something here. This is the normal side flipped, and this is the symptomatic side.
All right, and so the symptomatic side anteriorly looks like there's some fluid extending, or is there disruption of the ligament there anteriorly? Right there, yeah, it doesn't look normal as compared to the other side.
Yeah. And then there, that's a T2 weighted image showing the fraying and the tearing of the ligament.
There's also separation on the medial side. I mean, on the lateral side.
Over here. Yeah, a little bit of asymmetry there. You're right, John. Good pickup. And then, so this is a, and then.
So this is one where you scratch your head and figure whether you want to operate or not.
Yeah. So this is a tibionavicular ligament tear. This patient. This again was not acute. This was kind of it'd been symptomatic for about 6 weeks during the course of playing baseball for the Angels, and they elected to treat this non-surgically. Okay, Michael, what do you think of this one?
Okay, persistent medial ankle pain after sprain. So we see a lot of increased signal and kind of irregularity within that deep deltoid ligament to less in the superficial. It looks like there's maybe some fluid signal at the interface with the talus. And then you're pointing there's widening of that, syndesmosis with fluid there. So there's probably syndesmotic injury as well that we probably can't see on this one.
Right.
So they have a pretty, high-grade sprain of that medial deltoid ligament and probably syndesmotic disruption.
Okay, I agree with everything you said so far.
And then these are
here. The patient was
isn't that
tender right here.
Isn't that like the superficial or retinaculum and it looks sprained?
Yeah, some people call this the Laciniate ligament. It's that
or the retinaculum.
Right, and it's actually stripped off its attachment to the medial malleolus, the periosteal stripping here as well. Okay.
And there's a fusion also.
So 12-year-old with a medial ankle mass. We have some, looks like obliques and coronals. Again here, I wonder if this is another retinacular injury. There's that fluid signal intensity kind of along the superior aspect of the retinaculum.
Tear of the Laciniate ligament and a little bit of stripping off the periosteum in this location. I've not really seen much written about this in the literature, but this is right where the patient was symptomatic, and you can see the edema right where they felt the mass and the stripping of the periosteum. Yeah, Ashu?
Here we can see an avulsive tear at the capsular attachment at the talonavicular joint. Right there, yeah. It's a little bit more prominent on sagittals, but you can see it on the coronals as well right there.
Here's the plain film.
And you can see the osseous fragment there, so that one's a little bit more obvious.
Yeah, so that's a dorsal talonavicular avulsion injury. As you've already seen, if you look at most adults and older individuals, you're going to see degenerative changes here at the dorsal talonavicular joint space. We'll often get osteophytes in this location and often thickening of the capsule here. This is a common area of strain. And it's one of the most common locations of early development of degenerative disease due to strains of this dorsal capsule and then the healing response that you get from this. This is just an acute tear from a motor vehicle accident or a subacute tear from a motor vehicle accident. Okay, Michael, what about this subtle case?
Wondering if it's just all positioning. No, I'm just kidding. So there's, marked widening and disruption of the mortise joint. I mean, that's more than like a centimeter with, angulation. And I don't, it's like completely angulated and tilted. There's complete disruption of that deltoid ligament, and superficial and deep is there. There's got to be syndesmotic, seen on the axials, complete syndesmotic ligament disruption, and kind of there's dislocation of the fibula and the tibia as well, with some posterior subluxation of the fibula. And then we see right there's actually a distal oblique fracture of the fibula. I don't see a malleolar fracture.
Right. So,
on this cut.
Lateral fibula is, fibula is fractured, I think.
Yeah, distal oblique right through there.
Yeah.
The PTFL might still be intact on that one cut that we're looking at.
This more than likely needs operative procedure.
Yeah, right. Yeah, so this is kind of a high force supination eversion type injury here, where you can actually see the oblique fracture that talked about before, and the avulsion injury here of the deep deltoid and all the bony displacements. And
with these, you put the distal fibula in anatomical position with screws and a plate, and the medial side, you don't repair the ligaments because they just will heal anyway.
Good.
But you can't leave any separation. So if there's separation, then you have to operate there too also.
Good. Thank you.
Usually you wind up operating on both sides of the ankle.
Okay.
I was wondering if, I feel like I don't usually see a lot of MRIs of, cases that are this disrupted. I don't know if a lot of times they just take them to surgery without the MRI.
Operated on, and before you guys see it, they're operated on that same afternoon, or they don't wait for these for an MRI.
Right. Yep.
There's no reason to, because you're going to operate anyway.
Yeah, and if you go back here to this HSS article, their criteria for surgery. Oops, where did I go? Somewhere. Yeah, if you have greater than 5 millimeter separation, go straight to the operating room. You only get an MRI if there's less than 5 millimeters, and this was.
They got an MRI, but the thing is, so you get an MRI, you have a 3 millimeter separation. Now what do? You operate in most cases. It's where you're trained, and that's what you do. Campbell's doesn't exactly tell you what to do either.
Okay. So here's the Tibiocalcaneal joint, right in here. Here's the anterior process of the talus, the navicular, and the cuboid right in through here. And it's also called the bifurcate ligament. It has a medial limb, which is called the calcaneonavicular ligament, and the lateral limb, which is the calcaneal cuboid ligament, right through here. In that location. And here's what it looks like on the sagittal images. Here you can see the calcaneal cuboid and the calcaneonavicular ligaments in that Y kind of shaped configuration. The two ones right there. Let's see. And you can also look by ultrasound, though I, as you know, much prefer MR. So let's go on to the spring ligament. And there are three components of the spring ligaments: the superior-medial, the medial-plantar oblique, and the inferior-plantar longitudinal. So as you call these, superior-medial, oblique, and the plantar longitudinal. Here, if you see the posterior tibialis tendon coming across here to attach to the tubercle of the navicular, what you see is that there's a plantar longitudinal ligament down here between the calcaneus and the plantar aspect of the navicular, and then we have the oblique component, and then the superior component of the spring ligament. Okay, so here's an example of the inferior plantar longitudinal going, and then the oblique going to the tubercle, and then here is the superior component which goes over the distal PTT. Looking at it, we can see them here. Here is the plantar longitudinal, the oblique, and the superior over here overlying the posterior tibialis tendon. There's the calcaneus, here's the navicular beak, there's the navicular tuberosity, and these are the different components of the three components of the spring ligament.
That's a cadaver.
Yeah, a cadaver, right. So in the coronal plane, this is the plantar longitudinal, which we can see here going between the calcaneus and the beak of the navicular. The sagittal plane, we can see it right in through here. I'll show you in a minute. I really prefer the axial plane to evaluate these. And here again, we can see this is actually the oblique component of the spring ligament there. This is the substentacular talus. There's the navicular, the beak, and the longitudinal component is a little bit more lateral and more plantar here. Okay, so in the axial plane, we can see it very nicely here, where if we go down close to the plantar aspect of this complex, we can see the calcaneus and the navicular beak, and then this is the plantar longitudinal. Then we see a space here that's usually filled with fat or fluid, and then we can see the oblique component here going up to the tuberosity of the navicular, and that location. Here's the PTT, and the superior medial aspect of the spring ligament will be up another cut higher, which would be soft tissue plane here, which is difficult to just detect, and it's deep to the posterior tibialis tendon. So here on the T2 weighted images, we can see the plantar longitudinal component. Here's the oblique component, that fat in between the two. This is another cut higher showing the oblique component And we're just a little bit, yeah. And then here's the PTT. Medial plantar oblique. There's the inferior plantar longitudinal. And then here's a case from the literature where we can see fluid in between the two. Here's the oblique, and here we can see a tear, the plantar longitudinal right in through there. On the sagittal images, we can see the tear right here. But you have to be a little bit careful on the sagittal images, because often the sagittal images will go obliquely and not right along the inferior plantar longitudinal, so you can look like a tear, but it may be that you're just obliquing it and you're getting out of the tendon, so you have to confirm that on the axial images.
One of the things in an acute situation is very difficult to move the ankle around in the foot because it's very painful to do. So you have to go with morphine and Demerol or one or the other to position, and then it's pretty hard to hold that position because patient's probably screaming at you.
See, who's next? Okay. It's hard to see just because these are just selected images. But you can see that the mortise joint looks like it's not congruent. And also, this is not a normal orientation here between the talus and the calcaneus.
Are you speaking into the mic?
So what do you think? No, I'm just talking to Jennifer right now. She's going to talk into the mic.
Yeah, so I think it looks like that there is a dislocation, subluxation type of injury, and there is increased signal intensity in that superior aspect of the spring ligament. It looks like it's completely torn. There's a lot of fluid there, and also it looks like dislocation of the Tibiocalcaneal joint with fluid and in the sinus edema in the sinus tarsi. And then here again we can see dislocation of the joint, and here it looks like we're looking at another component of the spring ligament that's irregular and increased in signal intensity. And then here again, I think here we'd be looking at that oblique portion of the spring ligament, and I don't see it well.
So this is actually the plantar longitudinal component here.
Okay, so longitudinal.
So this was a talotarsal dislocation with tears and stretching of the plantar longitudinal and oblique components of the spring ligament, and you can see now we have an acquired pes planus.
Yeah, you got a flat foot.
Yeah, flat foot. And there was also an injury to the distal posterior tibialis tendon as well in this particular case.
And then this is an operative case.
Yeah. Good. Ashley, what do you think of this one?
18-year-old female with pain and swelling for 6 weeks after a fall. Looking at the talus, talar neck, and distal talus, there's quite a bit of trabecular injury and moderate bone marrow edema. Looking at that, is that the oblique portion of the?
Longitudinal.
Oh, it's the longitudinal portion of the spring ligament. It's definitely thickened.
This is the beak right here.
Oh, okay. Looks thickened, and there's some increased signal in there. I don't know if there's a discrete tear. There's some remodeling there of the posterior talus. Inferior talus.
Yeah, this was a fall 6 weeks ago.
Okay.
And then we can follow that across.
Now it looks like it's torn on that slice.
And again, my experience is you've got to be careful about the sagittal plane. So let's go to the axials. What do you see on the axials? And this
so on the axials, I do see the I don't see the it looks like I can't really see the plantar.
Okay. This is the plantar longitudinal. This would be the beak, and we can see there's a tear here and a lot of
Yeah, there's a tear there. I mean, I think it's disrupted, yeah.
And then we actually don't see a good oblique ligament either. And there's that space in between the two. And then we can see a type 1 accessory navicular
Possible.
vesicle, and then some bone edema as well. So this turned out to be a partial tear, but of the inferior plantar longitudinal and the oblique components. Okay, and then let's go on to the posterior ligaments, and there are three major ligaments here that are pretty constant: transverse tibiofibular, the tibial slip, and the posterior talofibular. So this is what it looks like from behind. We can see here's the posterior talofibular ligament, the posterior tibiofibular ligament, and there's an oblique ligament that goes across here, which is called the tibial slip. And this is kind of what it looks like on a low field MR imaging. There you can see the tibial slip coming across there. Here we can see, looking posteriorly there, there's the posterior tibiofibular ligament. Now in this particular case, it's kind of thickened. And what you see here is a prevalence data from this.
That's not acute, is it, John?
No, this is not acute. And then we can see inflammation of the bone here. And if we go, this is what the STIR images shows, maybe a little bit of edema here, but a lot of thickening of that posterior ligament. And if we go farther over, it's getting very thickened here. And this is, when you get hypertrophy of these ligaments, it is one of the many causes where you can get posterior impingement. But we'll talk about all the documented causes of posterior impingement later, probably in the next lecture. But that's one thing to look for. Okay, Michael, what do you think of this case?
Okay, sorry, I had to step away real quick. 26-year-old male, subacute sprain with lateral pain, rule out loose body. Lateral pain. You know, I wonder if I see increased bony density kind of right there in that clear space. There might be a little tiny little thing right there. Tiny little bone thing. I can't tell if that's...
Okay, there's the MR.
Okay, so there's increased signal within the PTFL, kind of fluid density signal, or it might just be windowed. There's some maybe, I don't know if that's a non-fat suppression, or if that's a real signal within the distal fibula, or is that incomplete fat suppression? Just that.
Probably incomplete fat suppression. But what we
Got it.
thing here.
So I'm not sure what that is. I don't know if that's not just fat interposed in. I'd want to see a. So the ATFL looks grossly intact, and the PTFL has fluid signal at its interface at its attachment.
Yeah. Well, this
so I don't know if that's actually a little bony avulsion off the fibula.
Goes all the way across here. Now this is actually an avulsion of the posterior talofibular ligament.
Yeah.
Coming across there. So if
Like, is there actually a piece of bone attached, you think?
Yeah, that's an avulsion fracture right here of the posterior talofibular ligament. Right. Okay. All right. And then we could go and we'll talk about sinus tarsi. There are three structures in the sinus tarsi. There is the Tibiocalcaneal or interosseous ligament, the cervical ligament, and the retinaculum. And two of these usually tend to be prominent, and the third one not so prominent. Usually it's either the cervical or the retinaculum that's not so prominent. And in this area, you get sinus tarsi syndrome, which is defined as pain in the region of the sinus tarsi with instability and weakness, relieved by local injection of lidocaine in the old days. The etiologies are primarily ligament disruption, and the most common cause of that are inversion injuries of the ankle. You can get also disease in here from rheumatoid arthritis, osteoarthritis, gout, and rarely you can have masses in this area, though, that I haven't seen. Almost always it's going to be from prior inversion injury. So this is the sinus tarsi we're all familiar with. You should have normal fat in it like this. This ligament that's more anterior that goes between the calcaneus and the distal plantar aspect of the talus is the cervical ligament right in through here. If you go farther out, you can see these strands of ligamentous tissues that go out into the soft tissues. This is the retinaculum, and it's usually multi-stranded like this. If we go in the coronal, here's the sagittal plane. This would be just a partial volume of the cervical ligament here. This is the interosseous ligament, which is more dorsally located, and it's in a different plane. In fact, they're a little bit like the cruciate ligaments. The cervical ligament and the interosseous ligament project in different directions, and the two together help stabilize the subtalar joint space here. And here we can see the interosseous ligament tends to go from superior medially to inferior laterally. The retinaculum is a structure out here laterally, which we're seeing in this area. We don't see the cervical ligament in this case because it's coming in and out of the plane in this particular location. So the most constant ligament here is the interosseous ligament. So we can see it coming across here from superior medially to inferior laterally. And here we take 2 images to see it because it's a little bit oblique to the coronal plane. On the axial images, this is the interosseous ligament coming across here. The cervical ligament is more distally located, mostly straight in the sagittal plane, and it attached to the right in through here, which we can see. So that's what we look for. So here's a patient who had pain deep in the ankle area, and this is a tear of the cervical ligament in someone who had classic symptoms of sinus tarsi syndrome. And these are almost always due to prior inversion injuries or ankle injuries. And inversions are just the most common ones. Okay, let's see, who did the last one?
I think it's my turn.
Okay. Another patient.
So here we can see that there's some effacement of fat and fluid in the sinus tarsi, and I don't see that cervical ligament very well. So this could be a ligamentous injury, and it could be seen with sinus tarsi syndrome.
So this is a patient with sinus tarsi syndrome. We're just partial volume the mid portion of the interosseous ligament here, so we need to see that in other planes. And this is a tear of the cervical ligament, which has led to instability. And here we can see eburnation of the subtalar joint space and all this fluid, as you were saying, in this area, which is abnormal, which goes along with sinus tarsi syndrome, and maybe some instability of some of the other joints as well. Okay, and sometimes, as all we see is lack of fat on T1 weighted images. If you look carefully, you can usually see a ligament injury in these patients. Ashu, what do you think of this case?
So on this case, we can see that there is, I think these are cysts within the sinus tarsus. There might be some disruption. You can see the cyst kind of extending laterally as well. Again, concerning for sinus tarsi syndrome, and this could be secondary to chronic instability. On the prior image, I actually did not see the cervical or interosseous ligament very well, so that could be disrupted as well.
And they were torn, and it led to sinus tarsi syndrome, and in chronic instability, you can get these large cysts, which also go along with the syndrome. Okay, Michael, normal or abnormal?
Abnormal. All right, so there's complete effacement of the sinus tarsi fat. There's also marked cystic change and edema in that adjacent calcaneus. And then there's, patchy edema throughout the talus as well, and I think even the navicular.
Okay, and the ligaments?
I don't really see the ligaments.
Yeah.
So I'm wondering if they're just, completely degenerated from sinus tarsi syndrome.
This is kind of the end stage, at this point. So, John, do you have any comments on sinus tarsi syndrome from an orthopedic standpoint?
The treatment is fusion.
Okay. Yep. Good.
And there are several different procedures. So, and I don't have a particularly favorite one.
Okay.
I haven't done a case in a long time.
Okay.
These are not that common that you see them, and they wind up in the hands of orthopedic surgeons who do feet for the most part.
Yeah, great. Okay.
So here it does look like there's some widening of the lateral ankle mortise, and there's a lot of fluid and edema in the sinus tarsi. There's also some increased signal along the distal fibers of the deltoid ligament. I think there's probably a tear of the deltoid ligament. Here we can see edema and fluid signal in the sinus tarsi and marrow edema within the distal talus. It looks like kind of chronic instability. There's some erosive changes and osseous remodeling. So I think this would be like a chronic sinus tarsi syndrome.
Again, another case of chronic sinus tarsi syndrome, and this was due to rheumatoid arthritis. And there's actually a lot of synovial thickening in through here. And there's
a lot of motion, isn't there?
Yeah, a lot of instability.
A lot of pain.
Okay, Ashu, what do you think of this case?
Here we can see that there's some edema of the articulating talus, and then there's effacement within the sinus tarsi. There's a pretty big ankle effusion. There might be some pes planus deformity. It's hard to tell. There's erosive changes and remodeling of the inferior talus there, talar neck. Yeah, you can see some cystic changes as well. And there might be some, psoriasis. Okay.
This is psoriatic arthritis causing sinus tarsi syndrome. This is
effusion.
Effusion. That I'm not sure how well this particular one worked because the patient was.
It doesn't look like it did the job. That's a device that's used, a screw type of device with bone put inside, and there are holes around it, supposedly to allow the bone to heal and fuse the Tibiocalcaneal joint. I've never used one. I always use bone packing, and that works out pretty well. That and fixation.
So here the ligaments really that try to stabilize the talocalcaneal tarsal articulation here and through there. And we've talked about one of these, the bifurcate ligament here, calcaneal cuboid ligaments out here laterally, and then the dorsal talonavicular ligament there. And this joint is called Chopart's joint. And then
a lot of these, John, as I'm sure you're going to tell us, involves not just one area of the foot. More than one ligament is almost always involved in a significant injury.
Yeah. So in this particular
or fractures. Fractures probably are more common than multi ligament injuries.
Okay. In this particular paper, what they found is that if you have people with inversion injuries to the ankle, which are very common, almost a quarter of them will actually have significant injury of Chopart's joint. And most of those that do have lateral collateral ligament injuries, if they're bony injuries, they're commonly seen, but injuries to Chopart ligaments are actually mostly missed. About only 17% were prospectively reported. And the bottom line here, as they're saying, is that radiologists tend to see the anterior talofibular ligament injuries and the bony injuries but they don't look at these ligaments that are involved with Chopart's joint, and they're commonly missed, and people can go on to chronic pain syndromes because of instability at this particular joint space. So they make a plea to be sure and look at Chopart's joint in patients who have significant inversion injuries of the ankle.
Well, one of the problems is that the treatment, a lot of orthopods let the patients walk a little too early, and the ligaments never heal, thinking that activity puts the patient back in motion faster and active duty or whatever. I'm a believer where you immobilize long enough to at least get the tendons and ligaments together where they belong for a period of time, so they can join together and allow you to dance. But and don't let them out of the cast too soon. I think that's one of the problems. 6 weeks is my
Okay.
treatment.
Good. Who's next? Ashu. Ashu, what do you think of this case?
33-year-old male, twisted foot, playing basketball 2 days before imaging. So there's a prominent osteotrigonum, almost looks flipped. There's quite a bit of an effusion here, and then I think there's this fluid anterior to the talus. I don't really see the articulation well there. Yeah, a lot of edema there. Could be a Chopart injury.
Where's the navicular?
Yeah, I don't see it.
It's out in space someplace.
Here are the axial images.
Wow. So complete dislocation of the navicular, and I think this is. It looks like it's pointing inward. There's quite a bit of angulation too.
And you can see why you can't relocate this. The bones are really locked together here.
This is a high velocity injury, more than likely.
It was a basketball injury.
Yeah, well, these guys are big and usually, and
a lot of force.
When they come down, that's a lot of velocity.
So this is a complete dislocation of Chopart's joint.
This will wind up in an operating room.
Yeah, right. So he walked around on this for 2 days
with a bunch of pins, and
yes.
Usually K-wires are very common in foot surgery.
Yeah. Okay, so I'm going to go on to a little bit different topic. So why don't we stop here and we'll pick up again on Thursday. Okay? Any questions?
No, thank you.
Thank you.
What are you going to go into on Thursday?
We're going to go into Lisfrank's ligament.
Okay. Have a good couple of days there.
Have a good one.
Okay.
At least tonight.